Up next, to make the case for prevention, please welcome David Waters, CEO of Community Servings, Dr. Bechara Choucair, Chief Community Health Officer at Kaiser Permanente, and Dr. Shaun Coughlin, Global Head of Cardiovascular and Metabolism at the Novartis Institutes for Biomedical Research. Here to lead the conversation is Atlantic staff writer Olga Khazan.
Awesome. Well, thank you guys for being here. We're here to talk about chronic disease, which is now the main kind of illness affecting Americans and is actually leading to a decline in our life expectancy. And I'm here with three people who work on different elements of that. So we've got sort of basic science and public health and prevention, and we've actually got treatment through food as medicine. So we're going to hear about all those three different elements today. So first, I wanted to just start out with you, Bechara, and tell us about the zip code effect and why it is that in the U.S., where you live can have such an important impact on how healthy you are.
Yeah, I think we all know by now that health happens where people live, where people play, where people learn, and health does not just happen in the four walls of our hospitals or medical office building. And I think we're learning from research that where you live impacts how you live, and how you live really impacts your health outcomes, your life expectancy, and that's why we're seeing people across the country in the United States living just a few miles apart, having completely different set of health outcomes, completely different set of health expectancy, life expectancy. And this boils down to the fact that what impacts health is not just the medical care. What impacts health is the socioeconomic factors. It's the built environment that you live in. It's your behavior that you exhibit. And those are really important things to help us think about chronic disease prevention before it gets to the medical system.
And I wanted to, just sticking with you for a second, so before this you were in Chicago. What did you see in Chicago? What were you able to do through policies in order to really improve public health on a major scale through just simple changes in the way policies are done?
Absolutely. So for 5 years, I served as the health commissioner for the city of Chicago, and we focused on creating the right policies, systems, and environments to create healthier livings for our residents. And I'll give you one example. High school students in Chicago in 2001 were smoking at about 25% rate. Fast forward this to 2017, only 6% of high school students smoked in Chicago. And that wasn't just because we've counseled students, we've educated students. Those are really important, but it's really because we've worked on the policies that make it more difficult for kids to pick up cigarettes and become smokers. So we've worked on making sure that the pack of cigarette costs a lot more money. So Chicago has the highest combined taxes, state and federal and local, when it comes to the pack of cigarette. It's one of the most expensive in the country. We've regulated flavored tobacco, and flavored tobacco is really what gets kids addicted to smoking and turn out to be smokers. We've also regulated e-cigarettes, and most recently, the city of Chicago raised the minimum age to be able to purchase cigarettes to 21. So it's that part of looking at 4 different sets of policies together, cobbled with education and counseling, that really led to that significant decline in smoking rates in the city of Chicago.
Wow. Do you know how many other cities have done that whole slate of policies?
When you look right now, cities across the country are trying to think about what are the types of policies we need to be thinking about to improve community health. One of those organizations is called City Health that identified a set of 9 policies that have the evidence that if those cities adopt those 9 policies, community health will improve. It's Tobacco 21, it's Clean Indoor Air Act, it's inclusionary zoning for housing, it's early childhood education, it's complete streets. So there are sets of policies that we have the evidence that if cities and municipalities adopt these policies, chances are we're going to improve community health. And that's an exciting part for an organization like Kaiser Permanente that has 12 million members in communities where 65 million people live. And we want to make sure that our members are healthy and our communities are healthy. And a key way to get that done is through policy change.
Right. Okay, so we can change the policies For the time being, though, some people are still going to get sick. When they get sick, David, that's where your organization steps in. So tell us a little bit about what your organization does and the impact that it's had, or the evidence that you have for it.
Sure, absolutely. So Community Servings is a medically tailored meals program for people with critical and chronic illnesses. We feed about 2,000 people a year here in Massachusetts, and we offer them complex medical diets where we can take 15 different medical diets to control for potassium or glucose or vitamin K, but we can combine up to 3 of them in the same meal. So a patient gets beautiful scratch-made food delivered to their home, and it's customized to their particular medical needs. In some cases, we're feeding their whole family, and in other cases, it's strictly the patient, depending on who's paying for it. But what we're really interested in is proving return on investment such that we can make a healthcare argument that insurers ought to pay to feed their sickest patients. Not feed everybody like a public health intervention might be, but really feed those people where their poor outcomes are directly impacted by their diet. So we just published a study last week in Health Affairs that proved a 16% cost savings for patients who we'd been feeding dual eligible patients. We've been feeding for a minimum of 6 months. And it was less ambulance usage, less ER visits, and less hospitalizations. All obviously very expensive. And the cost of the meal is so much less than that. You can imagine a 16% savings is considerable. We're now doing that same study on a much larger scale funded by Robert Wood Johnson.
So can you give an example of what one of these health conditions would be that's this complex that someone actually can't cook for themselves, and then what kind of meal would actually help with that?
Sure. So if a patient had advanced diabetes, if you have somebody in your family, you know this experience, that could lead to blindness and their inability to shop and cook for themselves. It could also lead to kidney failure and being on a transplant list for a kidney. My best friend is that case. And so that patient would need to control for glucose for diabetes, but they'd also need to control for potassium. Somewhere in there, they may have had a stroke as they got older, and they'd have to control for vitamin K. You know, this is a room full of healthcare leaders, but I would challenge any of us to walk to the store and figure out how we were going to control for potassium, glucose, and vitamin K. I've been in the food business my whole life, and I couldn't do it. So when you think of superutilizers, low-income patients who are very sick, can't even stand at the stove, let alone go to the store, we set them up to fail when we say, you know, almost glibly, control for these 3 different nutrients. They will go back in the hospital over and over. We have a patient who every month when her A1C went out of whack, she'd pick up the phone and dial 911. The ambulance would come every single month and take her to the ER. She got onto our meals program and she never, in 6 months, called 911 once.
Wow, that's impressive.
You know, I think this is such an important example that you're giving. And for us as a health system, we're starting to ask those questions to our own members as well. I'll give you an example. In Colorado, for example, we screened every one of our Medicare Advantage members, and almost 6% of those members have food insecurity issues. You know, in our pediatrics clinics, in one clinic, 12% of kids, in another clinic, 16% of kids are coming from families with food insecurity. And so we started building the connections in the communities for food banks and others, and create those referrals mechanisms. And that's for the general population, not necessarily people with specific diseases. You know, I think in California, we've realized that we have 238,000 Kaiser Permanente Medi-Cal members or Medicaid members who qualify for food stamps and don't get it.
Wow.
I mean, this is a significant number that we can support and help to make sure that those members are getting those dollars to be able to go spend it at the grocery stores in their local communities to be able to afford and put food at their table. So I think this type of work is so important from a community and public health perspective, and it's great that we're having this conversation.
Okay, well, Shaun, I want to fast forward with you all the way to the future into the world of CRISPR and gene editing. Can you talk a little bit about what you were telling us with the potential for? First of all, maybe you could give a brief overview of what CRISPR and gene editing is, and also how it could be eventually used for prevention.
Sure. So I'll lump CRISPR into the general and other technologies under the general heading of gene editing. There are certainly some diseases, many diseases that are driven either in a way that is highly penetrant and causes most people to be effective, or partially penetrant based on mutations that are inherited. And gene editing refers to correcting those mutations or replacing the gene that is defective. There are already examples of success. There is a wonderful case of viral-mediated gene replacement that is approved for the prevention of a particular form of inherited blindness. Novartis, just today, if you paid attention to the headlines, bought a small company that has developed a gene replacement therapy for spinal muscular atrophy, or the gene that causes that disease. These won't be treatments that impact the global public health, but for the individuals that are involved, the patient who is destined to become blind, they're obviously transformative. I think this technology is evolving rapidly. It's certainly likely that it will be applied to other diseases and may get to the point where it can be applied to diseases that affect more people. The risk-benefit will have to be worked out. Obviously, these therapies will have some risks associated with them. They're not perfect. They are manipulating the genome, and there are risks for cancer and other problems that come with that. But the technology is rapidly evolving, and it will be wonderful to see where it evolves to. The notion that we could perhaps intervene in people with heritable cardiomyopathies who are destined to heart failure is something to dream about.
So the sticking point with all this tends to be, how are we going to pay for it? So let's talk a little bit about payment. David, how are you able to get these amazing, tasty meals that are hand-delivered to people's homes paid for?
So we started out years ago as an HIV program addressing what was called AIDS wasting syndrome, which is essentially malnutrition. And it was a government-funded program through, you might know, Ryan White funding. But when we expanded to feed people with other illnesses, it all had to come through philanthropy. Now, it's great to do it through charitable work, but we got frustrated with the idea of sort of doing God's work, and that there was always a waiting list. There was always more people sick and needing our meals, and we could have 100, 150 people. So about 4 years ago, we started making the argument to healthcare leaders that really this was another tool in their toolbox and relatively inexpensive. If we prevent one night in the hospital based on controlling your diet, we save the system enough money to feed you for 6 to 12 months. Not everybody needs to be fed for 6 to 12 months, but even a dual eligible patient who might need to be fed forever, that could be cheaper than putting them into a skilled nursing facility to be able to keep them at home. Or Dr. Nabel's example in the earlier panel around home hospitals, we partner with Brigham's home hospital system as well. So we're making the argument that by proving an ROI, this is a reasonable service to be reimbursed through Medicare, Medicaid, private pay, et cetera.
And that also is because of the unique system that Massachusetts has, right?
It is, but there are programs like ours around the country in other major metropolitan areas. And once you prove a cost savings, then there's an incentive to put a program like this into any community that has a hospital or an insurer where they have expensive patients and it's diet related.
Right. And Bechara, you now are at Kaiser Permanente. Can you talk a little bit about how that hospital system is a little bit different from others and why that allows you guys to do so much on public health and prevention, even though typically keeping people out of the hospital isn't, you wouldn't think that that's that great for hospitals to do.
Yeah. So if you think about Kaiser Permanente, we've had the exact same mission since Kaiser Permanente was formed 70 plus years ago. And we are about improving the health and well-being of our members and improving the health and well-being of our communities. And we truly believe that those go hand in hand. So if we want to improve the health and well-being of our communities, we have to do a really good job at improving the health and well-being of our 12 million members. But make no mistake, there's no way we're going to optimize the health and well-being of our 12 million members if we don't improve the conditions for health and equity in the communities in which those members live. And when we do that, not only our 12 million members will benefit, but really all 65 million people who live in our communities would benefit. So for us, it goes core to our mission as an organization. But at the same time, we are both. We provide care and we provide coverage. So unlike most other health systems in this country that get financially compensated for providing more x-rays, more hospitalization, more surgeries, our financial incentive is to keep our members healthy, and we do whatever we can to make sure that we're keeping our members healthy, which means being out in the community, looking at policy, systems, environmental changes in our communities, so we can always optimize the health and well-being of our members.
Right, exactly. And Shaun, you transitioned from Novartis to a academia, really, and I was wondering what that transition was like, whether the incentives have changed at all, or how you think about drug development has changed in that transition.
So opposite direction, from academia to Novartis.
Oh, sorry about that.
So I was over 30 years at University of California, San Francisco, and just December moved to Novartis, and my prior career was all about discovery science, and I chose to have an opportunity to make innovative medicines to use the science to try to directly benefit patients at Novartis. Obviously I'm still on the steep end of the learning curve, 4 months in. It is interesting to see the effect of thinking about payers and markets on what we do. I think so in the cardiovascular field, we've got a wonderful set of examples around preventive medicine, and there has been about a 70–75% reduction in event rates over my lifetime. And the best estimates that I can find are that about half are ascribable to risk factor reduction, better treatment of hypertension, smoking cessation, less physical inactivity, lowering cholesterol, et cetera, and about half to better medical treatment, revascularization, secondary prevention with medicines. And so both are important, and we have a balanced effort with activity directed at prevention and activity directed at treatment. I think there's a real push to better subset patients, to identify patients at high risk for a particular condition, to understand the pathophysiology, the cause of a particular type of illness. For example, heart failure is not just one thing, it's many entities, and being able to tailor the medicine to the particular cause is increasingly important. It's, I think, best thing for patients because the benefit to risk is highest if you're treating the right patient with the right medicine. Makes scientific sense, and it ends up making sense from the perspective of getting the work paid for. it makes sense for us as a company that needs to pay for clinical trials. The trials can be smaller because the effect sizes are larger, and it makes sense for payers because the effect sizes are larger, and for society because fewer people are treated and the costs are lower. So it's been interesting learning about this world.
Yeah. It's always interesting. Well, I'm going to take questions from the audience in a second, but first, I have a question for you guys, which is, why do doctors know so little about nutrition, and what can be done about it?
I'll let the non-doctor answer first, then the doctor will come back.
As the non-doctor, I heard the previous Surgeon General speak about this last year and at a social determinants conference, and he said in his med school it was an elective, it was only taught on Saturdays, and it was 3 Saturday afternoons, and that was it for an hour. And when you think about healthcare, and so much of our body's health is related to what we put into it, what's the fuel, and that it just seems such a twisted system that there isn't a greater emphasis on it. I think that's changing. There's a great program in Tulane called the Gold Ring Center that's bringing culinary medicine into med schools. But I think I always say that nutrition is the poor stepchild of Western medicine. And I think we all have to work to bring the focus on nutrition when you think about what we all deal with around obesity and diabetes and concerns for other diet-related illnesses. A better understanding within healthcare of both what the patient's faced with, but also what's available for them to eat is so important.
Yeah.
You know, I think for me it boils down to 2 key issues. First is the education and the training, and I agree I didn't have a lot of training around education, around nutrition during my training as a medical student or as a family doc. And I think the other piece that's equally as important is if you ask the question, then what can you do about it? So I think what we're learning from our own systems, once we create the right infrastructure and support for our doctors and nurses, that if you ask for food insecurity and somebody says, yes, I skipped a meal last week, then we want to make sure that we have the right connections to food banks and other places to support the need of that member. So I think, I mean, for me, it boils down to screening and actually be able to connect. And the reality is, you know, we deal with that right now with firearm injury prevention.
Yeah.
You know, when it comes to healthy eating and smoking cessation and prevention from motor vehicle accidents, we have decades worth of research that tells us who to screen, what to screen, you know, when to screen, and then what to do if somebody screens positive. When it comes to gun injury prevention, we don't have that infrastructure. And that's why this morning, Kaiser Permanente announced a $2 million commitment to invest in research that help us understand how do we screen, how do we create interventions in a healthcare setting so that we can prevent injuries from firearm.
Yeah. I think we have time for just 1 or 2 questions if you guys have them. Questions? There's mic runners. Question over there?
So I'm Carolyn Grossman. Well, we have a lot of it right here in Boston. I'm on the board of Charles River Community Health. We have a program that we do in partnership with the Greater Boston Food Bank. We have at Charles River where 91% of our patients have been screened as food insecure right here in Greater Boston. 41% of our patients are on Medicaid, Mass Health. What do we do about that in Boston when we know that 70 to 80% of health outcomes are actually associated with social determinants of health, not with medical care. We're in the seat of the best medical care in the world, and actually, Mass Health doesn't pay for things like food, housing, language, translation. If you have patients that don't speak English in this country, they can't get their health care without translation. Mass Health doesn't pay for the translation services. Even though we have a health waiver here in Massachusetts, those things are not covered.
Yeah, I mean, I'll start if you want. I mean, you bring up such an important point. The idea of when we start thinking about chronic disease, we're immediately medicalizing the issue. But what you beautifully said, we know that what impacts health happens outside of the health system. So if we want to be truly making an impact on chronic disease prevention, we have to be thinking about policies. We have to be thinking about systems change. We have to be thinking about environmental changes. And for us as a health system, we think about those and we think about how do we meet the social needs of our members. Because at the end of the day, it's about, do you have good nutrition? It's about, do you have good education? It's about, how are you being able to get good jobs? It's about you being able to have a stable housing. And if we don't think about those, there is no way we're going to be able to optimize the health and well-being of our own members. So you bring up extremely important points.
Yeah. Well, I think that might be our time. Please join me in thanking David, Bechara, and Shaun.
Thank you.